Sir, can we start it?
We'll wait for 2 more minutes. Since people are still joining, 2 minutes we'll start.
Okay.
Amit, let's start. It's 4:05.
Good evening, everybody. Am I audible and visible?
Yeah,
Yeah.
You are audible, but not visible.
My video is on. I was not visible to myself as well, so I was searching for myself. I have joined through panelist link. Is it so?
yeah,
It's
that is the link, Amit.
even if I'm not visible, I'm audible. That is fine.
Amit, initially you were there, but
Yeah, I
right now
came from my phone to laptop.
Mhm.
So that was it. If it is better through the phone, I can. Now I'm visible.
Now visible, sir.
Now visible. There.
Please go ahead. Let's start.
Yes, sir. Good evening. Good evening, everybody. Today is a wonderful day and a happy Doctor's Day to everybody. And on the Doctor's Day, we are starting the nurses program. So that shows how much the doctors value our very loved and respected nurses who form the workforce of our NICUs, on whom dedication and sincerity and hard work, the outcome of the babies, it depends. So just to thank you all for joining in. I, Dr. Amit Upadhyay, Secretary NNF, along with Dr. Manoj, our President of NNF. We wish you, we congratulate you for joining this wonderful program conceptualized by the team of NNF members. And this will give, there are a lot of wonderful lectures in this. And all the nurses will learn a lot from that. This will definitely improve the neonatal outcome of the NICU in which you are working. And you will be able to save more and more babies, or you would be able to do the jobs which you are doing in NICU with a lot more conviction, with a lot more evidence. You would know that, okay, this has to be done. And this always gives you more confidence in doing what you are doing. So, not speaking anything much other than this, I would like to go on to our president, Dr. VC Manoj, again to welcome all our nurses and all our fellow faculties who are there for this wonderful talk by Dr. Sanjay Wazir sir. Over to Dr. Manoj for continuing from here.
Thank you, Amit. Respected seniors, esteemed nursing champions from across the nation, and my dear friends. It's with immense pride and heartfelt gratitude that we launch today NNF Quick Review of Neonatal Nursing, an initiative under our action plan for this year. Today marks not just the beginning of a refresher course in neonatal nursing, it marks our further commitment to reaching the unreached. We are honored to be joined by more than 4,444 to be precise, passionate delegates, nurses, educators, and caregivers who stand at the very heart of newborn care in our country. Friends, your presence here today reflects a shared commitment to uplift, empower, and standardize neonatal nursing in every corner of India. We know that newborn care is heterogeneous in the sense that we have standard of care existing in a place, and 100 kilometers away, we have very pathetic scenarios. So the journey of a newborn's life is fragile. And the first few hours and days are very, very critical, we all know. Nurses are ever-present guardians in that journey, advocates, protectors, and healers, I would call them. This course has been carefully designed to refresh essential skills and, of course, ignite the deeper clinical understanding and reaffirm the nobility of your role as the pillars of neonatal care in our country. As the president of NNF, I congratulate all of you for your dedication to neonatal nursing. Nurses, you are the front line in our collective pursuit of healthier beginnings and brighter futures. This course, with its focused content and accessible format, is our tribute to you, our way of strengthening the hands that cradle our nation's tiniest lives. Friends, today we begin with an insightful inaugural lecture on an overview of essential newborn care by Dr. Sanjay Wazir, a renowned neonatologist of a country from Gurugram, Haryana, setting the tone for a journey rooted in evidence, compassion, and collaboration. I sincerely thank each one of you delegates for showing up, for choosing growth, and for being the heartbeat of India's neonatal care system. Let me specially thank the advisor for this course, Dr. Ranjan Pajava. Sir has joined from US at 4:30 a.m. in the morning. Let me also thank all the members of my organizing team, right from my dear secretary, Dr. Amit, my committee chairman, Dr. Ramesh, and the coordinator, Dr. Binukutan, of course, our president-elect, Dr. Lalan Bharati, and so many others of the committee who have all worked tirelessly to bring this project to life. Friends, let us all continue to strive to reach the unreached, not just in geography alone, but in quality, equity, and excellence. I wish all of you a very happy and fruitful journey during the during the whole journey of this course. And mind you, this week we have set aside for knowing each other, getting things in place, and then we start with the next lecture from next Monday only. We will know the routines as we go along. I hope those of you who joined today have all downloaded the Telegram group for housekeeping announcements. Please convey the same message to even the others who have not done that. With this, let us launch this course. Thank you. Thank you so much. Now, I would request my dear friend and President-elect, that is President of 2026 of National Neonatology Forum, Dr. Lalan Bharati, to speak a few words. Lalan, you're muted.
Oh. Thank you. Thank you very much, Dr. Manoj. Good evening, everyone. I'm wishing you all a very, very happy Doctor's Day. It's truly honor and privilege to be part of this important occasion of launch of quick review for the nursing. I sincerely extend my heartfelt congratulations to our visionary president, Dr. V.C. Manoj, Chair Dr. Ramesh, Dr. Binu, and other faculty members for their dedication and leadership in bringing this initiative. It is heartening to know that more than 4,500 nurses have already registered for this course. This is really a fantastic response. This only reinforces the fact that nurses are the backbone of the NICU care. And strengthening their knowledge and skill directly translate into the on survival. And NNF has always been at the forefront for empowerment of the nurse. I recall when you were, Dr. Manoj, when you were the president of Kerala and I was secretary of NNF, we have launched 2 similar courses at Central NNF and Kerala. And that was a fantastic response and well accepted by the nurses. So I am confident that this course will do very well, and play a significant role in bringing down the neonatal mortality to the single digit. So my best wishes to all, and I assure that the such program will continue during my tenure and thereafter. Let us work together for our newborns and for our nurses. My best wishes once again, and thanks for giving me the opportunity. Thank you. Thank you very much.
Thank you, Lalan. Now, may I invite the advisor for this course, Ranjan Pejava, sir. Sir has joined from US for witnessing the launch and then advising us, guiding us in this course. Over to you, Dr. Ranjan Pejava.
Good evening, President V.C. Manoj, Secretary Amit Upadhyaya, President-elect Lalan, and members of the EB committee. Today is Doctor's Day, and it's a happy event that is happening today, the inauguration of one of the most important projects which NNF is launching. It is happier day for the nurses because such a program is being launched on the day dedicated to remember all the services and acknowledge all the help they give to run a NICU successfully. Nurse is a guide, friend, advisor, and everything to the patients and the caregivers. Empowering them is our duty. And proof of the pudding is in the eating. More than 4,000, nearly 4,500 members enrolling for the project is phenomenal. And it proves that nurses' thirst or hunger for learning and education is still alive. All along, even during my tenure and throughout my career, I have realized nurses are the ones who are very interested in learning and acquiring more skills and knowledge. So that shows their dedication to the cause. I appreciate the members, the coordinators, and Dr. Binu Kuttan, Nelby George, Palaniamma, and Dr. Ramesh Chandra, Archana, all the people who are involved in making this project a reality. We have just launched. There are a lot of things to do. It is a 5 months course. I came to know, and I know, and we have to maintain the momentum, maintain the interest of the participants, and it should be a two-way education with open discussions and feedbacks, etc. And I'm sure this will happen because, as Dr. Lalan Bharati said, Kerala NNF has been in the forefront of nursing education for the last 5 to 10 years at least. And I wish all the best to this project. And this will be a milestone project as far as NNF is concerned. And I hope even other organizations will learn from this and implement such good projects. So I don't want to stand between Dr. Sanjay Wazir giving the inaugural lecture and the participants. I can see there are nearly 200 people who have logged in. These are all testimonials to the interest and the success of this project. Congratulations to everybody once again, and JNNF. Thank you.
Thank you, sir. Now I would invite the chairman of the nursing course committee, the man who was running around along with the others to actually make this a reality and give a final twist to everything, Dr. Ramesh Chaudhary. Over to you, Ramesh.
Thank you, sir. So you speak a really big word that I still have to work more hard. My thanks to each and every participant. My thanks to the persons who founded the NNF and who dreamed about this day to come under the chairmanship of VC Manoj sir, our President-elect Lalan sir, past President Ranjan Pejawar sir, Amit sir, and so many NNF, because NNF is a shared vision organization and it has a long legacy of sharing, caring with the compassion. So my just one request to all the participants, this course has been designed with meticulous efforts by the so many neonatologists, practicing persons to equip you with the best of the knowledge that is based on the evidence. So keep your words open to communicate your queries with your faculty every time. Don't be shy to put any query forward to get it solved, because we want to reach everyone across the India to bring down the neonatal mortality. Second thing, I just wanted to one favor from each and every participant, that you just spread the word about this program to your colleagues who are still not in the role. So wherever our NNF team goes, maybe Manoj sir, Amit sir, Lalan sir, so everyone we will ask them, sir, please launch a course again for our remaining friends. So that is our ultimate dream, that over the coming years, our NNF keep on running this course, and this course can be refined only with your true feedback regarding methodology, regarding questions, and your queries that may affect the outcome when your practice get refined. I just second request for each and every participant, if you like to get it benefited for long run, I just request you, if you find this suitable, to enroll for your membership to the NNF fold. That will keep you updating regarding more such and such courses, because this course not only online module, this is also a offline contact where our faculty will come to your nearest hospital and will share you the real skills as well. So this two requests, I would like to thank each and everyone from the academic team who meticulously worked for the years to bring about this course, and our team who gave us the opportunity to work, and all the participants and founders of the NNF. Thank you. Jai Hind, Jai NNF.
Thank you, Ramesh. Now, may I request our coordinator for this course, Dr. Binukutan, who has been behind everyone to get things on time. So just give a brief outlay of the what lies ahead in the days, and then how to join the Telegram group and things like that. The basic things. Of course, the further discussions you can ask any of us, or you can chat here, or you can send personal messages to the committee team. Over to you, Binu.
Okay. Thank you, sir. Thank you all the leaders of NNF for this opportunity. And the main thing is that all the participant has to join the Telegram group. That is a rate limiting step. Everyone has to join in the Telegram group. We have already sent email to all participants by today evening. So requesting all to join. Those who are not joined, if any of your friends have not joined, please send them the link of the Telegram group. And all other communication we will give in the Telegram group. And all the lectures and videos are we will upload in our e-learning platform. We will text you details about that. And we are designed this course in such a way that your personal and professional life will not be affected. So this is you can watch at any time, and that questions also you can answer at any time. And further details we will share in the Telegram group. And further, this one also, lectures and videos we will upload, and any suggestions you can give us. Thank you, sir.
Thank you, Binu. As Binu was saying, please do. There will be some confusion still prevailing, I am told, regarding how to join the group and all. Please contact any of us and do that. Now we have a big committee of doctors and nurses who have strived endlessly to make this course a reality. I see so many of them here. And Dr. Brajendra Singh is a joint coordinator who has been actively pursuing the campaign. So, Brajendra, do you want to speak for a minute or 30 seconds?
Yes, sir. Thank you, sir. Thank you, Amit sir, Lalan sir, and Ramesh sir for opportunity. And sir, actually, I just want to request all participants to vision of this course like these to unleash. Sir, actually, many participants, many people requesting even now for the this course. So just I want to say all participants, please notify your colleagues and other peoples for the next possible second course, as we requesting to VC Manoj sir for, if possible, second course. So just inform, because you are easily reached, but our vision, our team vision is to reach unreach. So just notify that peoples for the second possible course. And wish you all the best, because we are not only treating the babies, we are treating the future of nation. So you are the most important thing, and NNF and our legends planning to skill you for the future of the nation. Thank you so much.
Thank you, Brajendra. So we are still dot on time. 4:30 we said we will wind up. So let us wind up with a vote of thanks. We have a nursing representative in our executive board, Palani Ammal. So may I ask her to propose a vote of thanks so that we can close the inaugural ceremony.
Yes, sir. Good evening to all. It's a great pleasure, privilege to deliver vote of thanks, and also thanks for giving me this opportunity. First of all, I would like to thank Lord Almighty for being with us for the success of the neonatal action plan. So, dear esteemed President, our Secretary, and past elected President, Coordinator, and Joint Coordinator, our advisor, and committee members, and the delegates. So, I would like to extend my heartfelt thanks each and every one of you for your invaluable contributions to the NNF quick review of neonatal nursing. Your tireless effort, expertise, and dedication have been instrumental in making this event a resounding success. To our President, thank you for your visionary leadership and guidance. To our Secretary and Coordinator, Joint Coordinator, your meticulous planning and execution have been truly commendable. To the committee members, your collective expertise and hard work have enriched this review beyond measure. And to our delegates, your active participation and engagement have been the livelihood to this event. So your collective passion for neonatal nursing and commitment for advancing our field have shown brightly throughout this review. So I'm honored to have been a part of this endeavor, and I look forward to seeing the positive impact it will have on our community. Once again, thank you all for your tireless efforts and unwavering support. Thank you.
Thank you, Palaniammal. So with this, we close the inaugural ceremony. And now we have the first lecture, an overview of essential newborn care by none other than Dr. Sanjay Wazir. Before we go on to the lecture, may I again thank all of you for sparing time for this long but interesting course, and all my committee members who have joined here especially, and then those who have worked for this. Thank you. Thank you so much. Now, over to you, Dr. Sanjay.
And thank you, Dr. Manoj. And in fact, I must admit this is quite a great symphony where on Doctor's Day you're launching the education for nurses, because if the nurses are empowered, you're looking at reducing the workload for doctors. So I think there's a hidden motive in agenda as well. But I must really appreciate kind of the great work everybody has done in the whole program to ensure that we are standing tall with our nurses. So without sharing, can I share my screen now?
Please go ahead.
Am I now visible and moving?
Yeah.
Perfect. Sure. Thank you so much. And we all will be starting with a very basic lecture about the essential newborn care. We all understand that the arrival of a newborn is a moment of profound joy, yet it also marks the beginning of a highly vulnerable period. We know globally there are nearly half of the deaths among children under 5 occur in the first month of life, with a significant concentration in the first initial days. In India, the challenge is particularly acute, with approximately nearly 1 lakh neonatal deaths annually, representing around 1/4 to 1/3 of the global newborn mortality. And striking, nearly 40% of these deaths happen in the very first day and half within the first week of life. Well, this concentration of early mortality highlights the critical importance of the immediate and the high quality care that we need to do. And if we have to achieve the single digit NMR, neonatal mortality rate, by 2020, then we need to cross this bridge with implementing timely interventions and looking at what intervention would be best in the first few weeks and few days, and especially on the first day, and more importantly in the first hour, and even more importantly in the first minute after birth, so called the golden minute, which helps us learn the outcomes. Now, there are 4 basic needs for every newborn that we talk about. There is about the one that the baby needs to breathe, and we need to figure out ways to make sure that the baby establishes a normal breathing. the child is entitled to a very warm welcome, and it is important to protect the children from hypothermia through protection of what is known as a warm chain. Now, whenever we have a new guest, we serve him the best food, and it is important that we need to give the mother's milk instead of any other like milk, pre-lactal feed, or any other modes of feeding, so that we can ensure the best survival and the best welcome for our child. And it's a tradition in our societies to go enter the temple where, after washing hands, we go eat our food after washing hands. And it is important to look after our newborn guests after washing hands and making sure that we protect them from all the infections that we can through various clean delivery practices. Now, the framework of essential newborn care is like a set of keychains which are intertwined together, and this includes the clean, safe birth, the thermal protection, early breastfeeding, and infection prevention, including the illness identification and cord and the eye care. Then going on to protect the warm chain with a kangaroo mother care, eventually integrated this into a family support, because most of the families would require some kind of a support to through the initial period. Then eventually going on to the home-based care, and you're also knowing about referral and follow-up. So these are all interlinked. So I mean, for example, the delivery room warm chain also needs to be maintained, warmth needs to be maintained after delivery also. Now we're coming to the first of these things is a clean and a safe birth. So first golden minute, as we said, like we have to make sure that we have to ensure a good respiration and a breathing for the child. A good air is what we need to give to the child, and for this we need to anticipate and prepare well in advance for the welcome of our guest. And we should also know our guest is going to be like, what is the kind of guest, what is his likes and what is his dislikes. So we also and we'll go to why anticipation is so important. We need to be warm and hygienic with gentle and quick action, timely actions, with good communication and coordination between various team members in the whole. And also, more importantly, we should know when the things are beyond us and we need to call for help, because of course we have in the whole system of things, there are people who are higher than us in terms of like their capacity and ability to handle the newborns. So we should keep them in the loop, maybe a little early, even if they are not called. So when I was said like we should know about our guests, we should know about the antepartum and the intrapartum risk factors, because it allows the healthcare providers to be prepared for potential newborn resuscitation and other emergencies that might arise at birth. Even though most newborn babies are vigorous at birth and only 10% require some resuscitative assistance, identifying risk factors helps in identifying the right personnel, right equipment, and other things which may be required for the welcome of these babies who may have certain risk factors for need for resuscitation. And if you can spot trouble before the baby is born, it's like doing a rehearsal before a big stage show. Everybody knows their role, everything is ready on time, help is just a call away. So this kind of preparation can make all the difference in saving the newborn's life. Now, when we're preparing it like a delivery room, we need to just prepare. First thing that we need to see, most of our guests would be better off like from the, they love privacy. So it is important that we maintain privacy of the birth by making sure that we close the windows and the doors and we draw the curtains. So not only it helps privacy, but it also helps making sure that the warmth, the radiant loss of heat, which happens through doors, windows, and the convective airflow and heat loss through the open windows is also reduces. So you need to switch off the fan and maintain a room temperature between 26 to 28 degree. And to ensure that, we need to have a warmer which is switched on at least 20 minutes before the delivery, and place 2 baby sheets before delivery to ensure that the baby is received in a pre-warmed sheet to maintain the warm chain. And most of the it may not be relevant to private, but like there is a newborn care corner in most of the SNCUs, which is a designated place for performing resuscitation. In hospitals which are private also, you need to have a dedicated corner which is dedicated to receive the newborn. So it has all the set of equipments and the supplies which should be ensured and checked before delivery. When it comes to checking the delivery equipment, so make sure that the essential equipment is in place and is in the working condition. So which includes the baby tray with the right amount of towels and the gloves and the cord clamps. Is there the cord cutting equipment, whether you're using a sterile scissors or a new blade for cutting the umbilical cord, a wall clock to announce the arrival of the guest, a self-inflating bag not not more than 500 ml with mask in 2 sizes is something which is required. A functional radial warmer which is switched on 20 minutes before the onset of the proposed delivery. An oxygen support to provide for a supplemental oxygen if required. A stethoscope for listening to baby's heart, and a suction machine. Ideally, if it is an electric suction machine is used, the pressure should not exceed more than 100. Now, as soon as the baby is born, the time of the birth is noted. Now, this is called allowed, so that you can actually document correctly, and this also tells everyone around that area that this is the start of a golden minute. Now, they receive the baby in a dry, warm sheets which have been pre-warmed under the radiant warmer, and they place the baby prone on the mother's abdomen, which is to ensure that you provide the right skin-to-skin contact to provide the warmth. It is important to turn the child to the head to one side, and secretions, if any, may be wiped clean from the mouth and the nose with the help of like a little bit of a sterile gauze. So after that, you probably would cover the child with a warm cloth, and this also helps stimulate the breathing. Drying thoroughly involves gently patting dry the arms. So don't rub it, but just pat dry it, so that the body, arms, legs and heads are kind of taken care of it. And delay the cord clamping by 1 to 3 minutes, so that there is a lot of umbilical blood which goes into the baby and prevents later iron deficiency in such babies. Once you've done that, there is like a crucial question that one needs to answer. One, you need to find out, is the baby crying or breathing? Okay, so that is like breathing is observed by watching the baby's chest. If the baby is breathing well, then he or she is crying vigorous, or he or she is crying vigorously and has good rhythmic chest movements. One should not be misled by a baby who's gasping, which is a series of deep, single, irregular so this is not rhythmic, this is not regular, and such breathing occurs when the baby is hypoxic or indicates a severe neurological or respiratory depression. So if the answer to this is that your breathing is rhythmic and regular and you are happy, then you proceed with the routine care. But if the answer is no, then you need to move to the resuscitation. So let's first take the baby who's breathing well and crying. In this case, as we discussed earlier, we just would need to look at keeping the baby on the mother's abdomen, making sure that the airway is open and clean, and you would need to cover the mother and the baby with a warm linen cloth, and that maintains the warmth and the comfort. You cut the clamp or the cord after 1 to 3 minutes. You start initiating breastfeeding within the first hour. but you also monitor. Although these babies have been labeled as breathing well, sometimes the secondary apnea can happen sometimes later also. So it is important that we monitor these babies on the mother's abdomen itself, and you do it every 15 minutes for the first hour and every 30 minutes thereafter, till we are sure that the things are doing fine. Now, talking about the second type of a baby where the breathing does not happen correctly. In this case, we need to do is to cut the thumb and clamp the cord immediately. If baby is not breathing properly, the warmer should be pre-warmed, as has been discussed earlier, with 20 minutes in the manual mode, and then you place the baby supine under the radiant warmer with the head towards the side opposite the display panel. So what it helps is in the full visualization of the baby, it prevents the baby from getting hypothermic, and also at the same time gives you enough space to work and move around the baby. So position the head so that the neck is slightly extended. I mean, as shown in this diagram. So neck, if it is flexed, if the airways are not open, it should be slightly extended, not too much extended, and should be positioned on the back with what you call the sniffing position. The goal is to move the nose of the baby as far anterior as possible without getting hyperextension. So, and you would need to clear the airway. So you need to clear the airway with a kind of a suction, which should not be more than 5 centimeter in the mouth and 2 centimeter in the nose, with not more than 3 to 5 seconds. If you do it too deep, what has happened is that it causes a vagal stimulation, which instead of stimulation actually causes bradycardia and slowing of the heart and slowing of the respiration. So it's not a vagal stimulation, it's a vagal dampening which happen, but because it stimulates vagus nerve, is called a vagal stimulation. So one would need to see if vigorous stimulation is not helpful. So if the child is not crying, throwing, hitting the child, flapping here and there, slapping the back, which we used to be a practice at one point of time, these would not really help. So if there is a possibility during this time, the position of the head would need to be relooked, because when you're doing that kind of a stimulation, the neck may have again flexed or hyperextended, and in that position you need to go back to this. So if the baby, like with this thing, only comes back and starts breathing rhythmically and regularly, in this case, we move the baby to what is known as observational care, which means that the baby and the mother would still need to be together in a skin-to-skin contact to keep the baby warm. And we would monitor the DO every 15 minutes in the first hour. And we check for breathing, temperature, color, and watch for complications. And if required, we refer the children immediately for further action. And we encourage the mothers to breastfeed the baby as soon as she is ready, and that should happen within the first hour itself, because earlier the breastfeeding is established, more likely that the breastfeeding would be there, exclusive breastfeeding would be there at the time of discharge. And also this helps prevent hypoglycemia or low blood sugar in the baby. Now, if the baby does not breathe even after getting, so if the baby is like, you are trying to look at the breathing, and after your gentle stimulation and your suctioning, clearing the airway, the child is not not breathing, further tactile stimulation beyond the 2 stimulations of the back, 1 or 2, does not, or giving oxygen in a child who is not breathing, does not really help. It would increase the risk of hypoxic injury to the brain. So in this case, the appropriate management is not stimulation, not oxygen, but to give a positive pressure ventilation. So positive pressure ventilation, which means that we are giving the baby using the bag and the mask, and we have to ensure 2 things here. One, that we know how to use a bag, because invariably the bag works and the mask works if it is like proposed on the face in an appropriate size. So you should know, like for example, on the diagram on the right, you see the extreme right baby is the one where the mask is rightly faced. But if the mask is too small, and then there will be leak around the nose. If it is like too big, then it is like going to leak again around the nose, but then because it will be covering and maybe a little bit beyond the chin also. So it is right to choose the right appropriate bone. And if you see on the left, the first one is the wrong way to hold it, because when the baby is moving here and there, if you're not holding the mask in a C shaped on the left side, then you're probably going to have a lot of leak. So if you do not use the bag and mask correctly, you probably would have a lot of leak and an ineffective respiration. So you see, if you know how to use the bag and mask correctly, then you need to initiate the ventilation with a room air. So you deliver 5 breaths. So once you deliver 5 breaths, you observe for a chest rise. And chest rise, like if you cannot see a chest rise, then I'll just like tell you what to do if there is a corrective action that are required. Then you would probably, if you see that the corrective actions have been taken, you can continue with the ventilation. If the chest rise is right, then you can continue with the positive pressure ventilation. But if there is no chest rise, so if you see it like somebody says, okay, the chest rise is not happening, this happens like because the seal is inadequate, or the airway is not open, or not enough pressure is being given. So in that case, one of the things that you need to do is like to reapply the mask as shown in the previous picture, that you need to apply it at the right position, and you need to maybe adjust the neck, because if your neck is too flexed, the air would get blocked. So you need to keep it a little extended in that sense. So if like after the initial 5 steps, the child still does not have like maybe I got it a little sorry. So if the child is still not improving, okay, in that case, that what we need to see, we go the same 5 breaths. So if this does not have, we give 5 breaths more. If the 5 breaths, sorry, this was slide. So if you go and look for, you've done the previous 2, like reapplying the mask, and you're correcting the neck, you see and look for, go through these steps again. You observe the chest rise again, and if the corrective steps have been taken, the chest is rising, you continue with ventilation. But if the chest rise does not happen again, then in that case, we should probably just look at what are the possible causes in that case. And in that case, you will again go and check for the mouth for secretion, suction the mouth and the nose as we discussed earlier, if necessary. And maybe you need to use a little bit more pressure on the rim of the mask and lift the jaw, the jaw lift a little bit more. So do not press hard on the baby's face, but you lift the jaw to keep it open, and increase the pressure by squeezing the back with a little bit more force, unless there is a visible movement of the chest. And so this would result in the better chest rise. And once the chest rises there, you go for the same kind of a ventilation. You see, observe the child after 5 breaths again. So at this point of time, it is important that if the child is not breathing after 30 seconds of effective ventilation, so you will still continue with ventilation, that is to maintain the oxygen supply to the newborn, but make sure that you call for additional help, because this is the time when you probably need to come in with other expertise also, to give intubation, to give maybe chest compression. So that would make sure. So once you call for help, you will still go ahead and observe the child with the ventilation. So you start ventilating when you have an effective the ventilation. You observe the heart rate after 30 seconds with counting for 6 seconds and multiplying it by 10. So if you have a heart rate of 6, then you give like 6 into 10 is like 60. But if you have a heart rate of 10 in 6 seconds, then it is like multiply it by 10, so you will get it, so 100. So if you observe and you see that the heart rate is improving, then you continue with the ventilation till the time you see effective rhythmic breathing coming up. If your heart rate is increased but your respiration is not completely getting better, you still continue with ventilation. But if the heart rate is still low, less than 60, despite effective ventilation, you may need other people who would be expertise in giving chest compression, especially if the heart rate is less than 60, and they may also need to have an expertise to give or intubate the child. So this ensures that we have given the safe welcome or a good fresh air to the child. And once the child is born, there are certain other things that we need to take care, which means that other cares after birth includes like the infection prevention. It also looks as a breastfeeding initiation, other cares like a cotton care, hypothermia prevention, and danger sign detection. So among the infection prevention, there are WHO 6 cleans that would need to be looked at. One is a clean hand. So as we discussed earlier, when we enter a temple, we wash hands. So we should enter our NICU with clean hands and try to see each god as a separate temple. So every time we have one child, and then if you have to touch the other god, then you need to wash hands in between. Then clean perineum, which ensures that the hygiene and there is reduced infection rate. The clean delivery surface, the clean cord cutting instrument, whether it is the clean blade or a scissor, and a clean tie. But most of the times we are using an umbilical cord clamp these days, which is sterile, and more importantly, clean towels and clean sheets. So these are 6 steps of of hand washing by WHO, and this needs to take 40 to 60 seconds. So using a sanitizer is good, but there's not a replacement for hand washing, especially if your hand is contaminated with an organic matter or a fecal matter or any other matter like this, proteinaceous material. It will never be clean even with the hand sanitizer. So you need to rub it off and use a sanitizer as in between process. So as we said, like we need to prevent infection. So one of the things that we need to look at is cord care, and cord care after cutting with a sterile blade or a sterile scissor. We also now are practicing cord care which is dry. So nothing to be applied on the cord or on the base, not even chlorhexidine, not even neosporin powder, not even triple dye, because these tend to cause irritation and may also cause potentially allergic reactions also. And dry cord care is standard of care for most of the babies. You should cut it at least 3 to 5 centimeters away from the umbilicus, so that if there is an umbilicus minor, omphalos minor, which is there in the umbilical cord, so it will not get really trapped into that clamp. So eye care is like you need to take a sterile gauze and gently clean the areas around the eye using the sterile gauze, and swab each eye with one, moving from inside to outside, and you would need to give it with a single swab for each eye. This reduces the chances of having ophthalmia neonatorium, but also it is important that we just discard the habit of breastfeed being put into the eye, which is the standard of care in some of the hospital, which is inappropriate, should not be done. And injection vitamin K needs to be given, although it's not part of the thermal care or infection prevention, but it is important that vitamin K should not be missed, because after the baby goes out of the delivery, one of the things that nobody remembers whether it's got a vitamin D, so it should be part of the armamentarium in the delivery room, where the babies who have a birth weight less than 1 kg, we should probably given more than 1 kg, sorry, 1 mt, and less than 1 kg, 0.5 ml. That needs to be given in as an injectable vitamin K into the anterior labor aspect of the thigh. So besides the thermal protection or the warm chain which is done at the time of the birth, we also need to ensure that the children who are there should undergo, whether it's a preterm or even the bigger babies, have a skin to skin care, a kangaroo mother care, and if the mother is not available for whatever reason, it could be any family member, which could be father, which could be the grandmother. It is about a kangaroo person care, like, so any person who's willing to be a kangaroo for the baby can give care to this, because the skin to skin contact increases the warmth that is provided to the child and reduces the chances of morbidity and infections in the child. As I said, it is important that we know to serve our guests with the best food, and exclusive breastfeeding at birth is the best start we can give to children in the first 6 months of birth. So the important point as a nurse that you need to know is that we need to see what are the points in positioning the infant. See, we generally, all of us, like, when we go and we tell the mother we should breastfeed the child, that thing is mother knows. What she lacks is sometimes the support in terms of finding what is the right way, because she is as naive as most of the male doctors that, for her it's the first time, for us it never happened. So for nurses are in the best position to provide that kind of a support, because we need to teach them alignment, we need to say how to position the baby's face directly towards the mother's breast for the easy access, how close to keep the baby, and you also need someone so close to you to provide that kind of a support for this thing. And it is important, as nurses we should probably look at what are the ways for us to find out about the signs of a good attachment, and in which the areola enters the mouth, the lower lip is flanged, and the child is able to put the whole nipple and the areola into the mouth. You could promote breastfeeding in any position, where sometimes, like, your cradle, cross cradle, or even lying down position where the mother is comfortable, because immediately a cesarean mother, sometimes the doctor is not allowing, say for the spinal headache, they say okay, the mother should keep lying down, but she can move to the side and feed to the child, and ensuring that your breastfeeding is maintained all throughout the day. Parents are often concerned about whether my children are going to get enough breastfeeding or not, and that is a concern which is valid, because everybody wants to ensure that, like, I'm not underfeeding and no complication happens. The way to check for the adequacy of the breastfeeding is that the child, like, passes 6 to 8 times urine in 24 hours time, but this may not happen initially. Initially, on day 1, the child may not pass urine, because there is a transient oliguria which can happen up to 48 hours in a breastfeeding baby. And after that, it is the number of days and number of urine. So if, for example, on day 2, the child can pass 2 times, day 3 is 3 times, and 4 days is 4 times. After 4th day, it is 5 to 6, like, minimum that the child should pass in 24 hours. Then the child should regain the birth weight by 7 to 10 days, like, and the child should be able to sleep for a significant length of time, usually 2 to 3 hours. But it is important that we do demand feeding. We don't look at a clock. So clock was devised at least 9,900 years after the humans came on this earth. So for the last 100 years that clocks have been, we are so much particular that the children should be fed every 2 hours, 2 hours. We should, for a term baby, we should do only demand feeding, unless there is a medical reason which has been described by the doctor or the medical professional that this child would need to be, like, doing the 2 hourly or the 3 hourly feeding. Now, we also need to understand, okay, when the child is, like, being fed, so there are key messages that we need to promote. So one, that we need to put the baby onto the breast as soon as possible after the birth, and preferably in the delivery room. If you, for example, do not do it after birth and you wait for 3 hours, many times the lactogenesis 1, or the process where the milk production flows in easily, does not happen. So that is why, if the child is fine and there is no reason for the child to be moved to NICU, the child should be put on the breast within the first 30 to 60 minutes, to ensure that the more oxytocin flows, the more let down reflex flows. And even if this looks yellow, the colostrum, that often gets, like, people think that the milk is not clear, it's been there for a long period of time, especially in my part of the world. Sometimes they tend to think like this. It is important to tell what is the difference between colostrum, why it is yellow, and why it contains more immunity, why it contains more like IgA levels. And this is going to protect you. Even if the amount is less, feeding this milk will provide not only nutrition but also prevent infections as such. And it is important that the child should be fed at least 8 to 10 times. So nursing should be 8 to 10 times. Again, as I said, it's not important to look at every 2 hours or every 3 hours, but it is important to look at, like, keeping the baby and the mother together during the feed, during the day and also during the night. And again, it is important for the mothers to be finding in the most comfortable position. What makes, because most of the mothers have some kind of a backache after delivery, so we need to ensure that they are comfortable